Okay, welcome to another Brokaw Radio program. This is a new program that we've been trying to get on for a while. It's called For Stroke Prevention. Our guest today is Lara Lieberman. She is the Stroke Program Manager at Providence St. Peter's Hospital. Welcome. How are you today?
I'm good. How are you? Thanks for having me.
Oh, my pleasure. Thank you for sharing with us. Um, let's start with a little bit about your background.
I've been a nurse for 20 years. I was a nursing assistant previous to that. In healthcare, in the arena of healthcare for about 22, 23 years, and really focusing on cardiovascular and, neuro stroke health. Worked in stroke units, cardiac units, and ER for about a decade, and have been running stroke programs at a few different organizations over the past over 5 years. And my kind of intention and my role is to help with stroke prevention. Of course, we love seeing people, but we don't want to see them under these circumstances if we can help avoid it. This is really close to my heart, and I appreciate you having me on here to talk about it.
Great. Thank you very much again. Most listeners of Stroke Warrior Radio have had or know about strokes, TBIs, or other neurological disorders. Briefly remind us and tell us, our non-stroke listeners, of what is a stroke brain attack.
So when you have a stroke, it's the result of, oxygen, which feeds our tissues all over our body. It's a result of an interruption in the flow of oxygen. That can happen because there's something blocking it, or it can happen because the vessel starts bleeding and the blood can't make it to where it has to go. So what happens is the tissue that's not receiving that oxygen starts to die. And it can accelerate based on how long it is not receiving oxygen and the area in which the oxygen is not getting received. Okay. So that's basics of what a stroke actually technically is.
And there's 3 different types of strokes, right? Or is it more than that?
Well, there are kind of 3 categories we look at for strokes. 2 of them, I would say, actually are strokes. And then we have that third TIA, which is a common kind of thing we hear about. And in each category, we have kind of subcategories of the types of strokes you can have in those. So you have an ischemic stroke, which is a fancy way of saying that we have a blockage of the blood flow. You have a hemorrhagic stroke, which is also a fancy way of saying that you're bleeding, and that's disrupting the flow. And then we have something called a TIA. And some people call that a mini stroke. And that's kind of a misnomer because, again, a stroke occurs when you don't have oxygen flowing and there starts to be tissue damage that results from it. In a TIA, it's a big warning sign, very important that we listen to it. And it is an interruption in flow that's temporary before the damage is permanent. But this, again, I'm going to stress, is a big warning sign that, unfortunately, I've worked in a lot of rural areas, and we see people that just want to finish out their day. And last time it happened, it fixed itself and it wasn't permanent. So they ignore it. And just because it stopped one time doesn't mean it'll stop the next time. So.
Right. That's funny because when I woke up from falling asleep on the couch, I took some ibuprofen and went to bed. I didn't call the ambulance till the next morning. So yeah, there are warning signs. What are the quickly, I guess, what are the signs of stroke?
So I have to say the brain is a very complex organ. So I could go on probably for an hour about all the things that can occur during stroke, and everybody's stroke being very different. But the alarming signs that really are a trigger, we use the acronym Be Fast. A long time ago, we only used FAST, and FAST without the B neglects part of the brain. So we want to include the whole brain when we're talking about strokes. So if you look at it, B stands for balance. And you're kind of looking at, you can have a vertiginous, we call it, or a vertigo, severe dizziness, that's kind of persistent. A lot of times we want to look at something that's acute onset, so all of a sudden happening. We have eyes, which is E. And one thing that occurs with eyes is that you can lose vision. When you lose vision during a stroke, usually it's in both eyes, and it tends to happen in a hemisphere, or what we call a quadrant, which means that half your vision is getting lost on one side, or a quarter of your vision on one side. You can have tunnel vision sometimes. We can also see blurred vision, but the really, really common one is that loss of vision, where you have like half the vision gone or a quarter of the vision gone. Next, we have the ones we kind of stereotypically think of when we have a stroke, the facial droop. And with facial droop, it's, with movement. So you have that muscular weakness. And if you ask somebody, I always tell my nurses, because not everybody's happy when they're in the hospital, that it's not just smiling, which we think of. If somebody frowns crooked or they're yelling at you and their mouth isn't moving evenly, that there's a lot of different ways to look at facial droop. But the best way is to just say smile. And if the person can and it's not even, that's a sign. Arm weakness and leg weakness on the same side, we call that unilateral. It doesn't have to, we don't have to wait until it's the not waiting thing that is so important. We don't have to wait till it progresses, which a lot of people, they were like, oh, it was weak, but I could still move it. And it's that waiting to see if things get better that is a problem. Speech with the S. There are two different issues with speech. One of them is slurred speech. I tell people sometimes it sounds like somebody had maybe a few too many drinks, or they're really slurring their words together. It can get so bad that you can't understand what someone's saying because they're so slurry. That can be a sign of stroke. Another thing is difficulty finding words. We call that aphasia, where you have trouble, identifying objects, or you just can't get out what you're trying to say. People sometimes mistake that for confusion. Sometimes we can't even understand what people are saying to us. Again, our brain is so complicated. So we really have to take that into account when we look at these things. And then T in the B fast is time. It's that thing I keep talking about, where you just want to get to the hospital as quick as possible, because that allows us to be able to do something. There are a couple treatments, and they're very time sensitive. So, making sure you get here is important. I do want to add that recently some people have been also saying terrible headache for T. That is a sign that often gets overlooked, that you have a severe headache. Doesn't get better. Do not sit at home, by the way, and try to take aspirin or anything like that when you have these things to make it go away. If you're concerned, please seek medical help, because there are medications that we can take, just trying to fix stuff on our own. And when it's alarming to this degree, really, let's get to a medical professional and see what they say.
Right. Thank you. Before we get into actual prevention stuff, who's at risk of stroke? I mean, what's the number one risk? Are there any other factors?
Yeah, so there are a lot of factors. I mean, obviously, we like to look at it, there's modifiable and non-modifiable risk factors. So when we talk about prevention, we're going to really talk about those modifiable risk factors, but there are non-modifiable risk factors. And some of those are age. As you increase in age, you're at higher risk for stroke. I do want to pause though and say that does not mean that you cannot have a stroke when you're younger. There is some sort of like misconception that it's just not a stroke if somebody's young. And that is not the case. We see pediatric strokes, those are a very different cause usually than adult strokes. And we see that I wrote down some facts. In 1993, we had 17 out of 100,000 people between the ages of 20 to 44 having strokes. In 2015, that number had gone up to 28 out of 100,000. So that is the highest increase in strokes for the population, is that younger group, that like high 20s and even below 50s, you're seeing the largest increase in percentage of strokes for that population. There's a lot of different causes. So, I mean, but age is definitely something we see. There's females and males. females have a little bit of a higher risk for a stroke, but they're kind of pretty close compared to some other things. However, females have a higher mortality with strokes.
Oh, I didn't realize that.
Yeah.
Wow. I've often heard that the number one risk of stroke is high blood pressure. Is that true?
That is. I have to be honest with you. I get nervous about qualifying one thing as our highest risk, because then people concentrate on that one thing and neglect all these other incredibly important things. And I will say, studies might not agree with my statement, but I'm going to stick by it and say that the highest risk for stroke is not taking care of your health and seeing your doctor. That is number one. And that will take care of your hypertension. That, look at your smoking, your diabetes, all these things we're going to go into a little bit more. And your number one step to doing that is seeing your primary care physician and following up on your health.
Okay. And that includes diet, smoking, drinking, drug use, those kind of things?
Absolutely.
I was surprised that diabetes is one of those for a higher risk. Is that correct?
Yes, diabetes is one of the highest risk factors for our patients for both cardiac and stroke. And what you'll see is we always say, it's all one system, right? Our blood vessels flow all over the body. It is, if you have something causing a problem in your brain like a stroke, it is not out of the ordinary to think that you might have blockages in your legs eventually, or blockages in your hearts. These are all your vessels in your body. So the risks are very similar. And diabetes is one of them for sure.
Okay. I also, I think people get them confused, at least I did, that a heart issue is not a stroke issue. But that plays into each other, doesn't it? I mean, one's a heart attack and one's a brain attack, in my mind.
Yep.
So is that irregular, or is that something that actually is related?
Well, it's related in the way that there's a correlation. So if you have heart disease, it is correlated with a higher risk for stroke. If you have a stroke, it is correlated with a higher risk for heart disease, because again, if you look at those risk factors, they predispose you to both of these things. So that's one thing. The other thing you want to look at is when you have an insult to your heart, it can cause other conditions that can lead to stroke. So atrial fibrillation, which we can definitely talk about as one of our, major things we want to look out for. It can be a result of an injury to the heart. It can also be a result of a couple other things. So that can lead to strokes. So stuff like that, if you have a major heart attack, you get something called cardiomyopathy, which is like a weak heart beating. It doesn't pump as strong as it should. That also can predispose you to having strokes because you don't have effective blood movement through your system.
Okay. I recently talked to a couple of my radio followers who had their strokes at 7 and 12 years old. That is shocking to me. I mean, you said the stats are going up. Is it also going up for under 20?
I have to say I'm not sure. I don't want to give you misinformation on that. I'm not sure if the numbers are going up. It is not a high incidence of stroke. And like I said, there are different causes. So when we talk about these preventative things, like with the diabetes, the hypertension, the smoking, these are things that really affect us as we get a little bit later in life. So we're not looking at necessarily the same disease process, although the result is the same in the end. So I will say, as a caveat to what I'm saying right now, is that I don't know that somebody would not call an ambulance quickly if they had a child that had stroke symptoms. However, don't ever wait because they're a kid and assume that that's not what it is, because that is just a really dangerous decision.
Okay. I'm probably jumping off the topic a little bit, but what is the percentage of people that have suffered sudden death because of a stroke? Do you know?
I don't. I'm not exactly sure. I do know that a lot of mortality in stroke is long-term. So it's secondary effects of having the stroke. I mean, you can have, especially with a hemorrhagic stroke, you can have an insult, or if you have what we call a large vessel occlusion, because our vessels get thinner as they travel kind of deeper into the brain is the best way I can describe it. So when you have these bigger vessels that get blocked, or you have a massive bleed in the brain, those are kind of more associated with what you're thinking about.
Yeah.
However, if you think about it, we put ourselves, when we can't move anymore and we can't necessarily eat or swallow, because somewhere between 30 to 70% of people have swallowing difficulty after strokes. So when we have all of these things going, I know it's a crazy percentage, 30 to 70. It's a very abstract percentage, but that's kind of what's published right now. And when you think about all these things, you can't swallow, you can't move, you're in a chair, then you get, malnutrition, you get pneumonia, you get what we call sepsis, which is an incredible infection all over your body that can come from either your urine or pneumonia or just a regular infection that spreads from a sore. So these types of things kind of over time can really lead to that, mortality. And that's why you have that increased mortality, because it's not just acute, when it happens, it progresses.
Wow. Besides identifying risk factors, let's jump to probably the most important step, and that's lowering the risk of stroke. I have very limited knowledge about that, obviously, because I had a stroke. So, I mean, what can people do?
All right. So again, we have these, so we class them as non-modifiable and modifiable. So when you have a non-modifiable risk factor, you have to realize that's something you can't change, right? I mean, we all try to change getting older these days, but it's not exactly something we're very successful at. So we're all going to age. So we really have to ignore these things and really focus on what we can change. And the first step is really seeing your primary care doctor on a regular basis, because we want to monitor for high blood pressure. We want to monitor for diabetes. People have late onset diabetes. We want to look at our weight and really be healthy with our diet, make good choices. And I can get more into that. Smoking, I told you, I had discussed this with a few neurologists prior to coming on to make sure we were all on the same page with what I was going to focus on. And unilaterally, everybody said, make sure everybody knows to stop smoking, which in this day and age, you would think people would kind of, know that, but man, is that a hard thing to do, right? I mean, it's just, yeah, it's really hard. But smoking, I mean, really is huge with strokes and heart attacks, honestly. And then if you look at exercise, people with a sedentary lifestyle are at higher risk for stroke. And there's a correlation with high stress and stroke. So, I mean, I work in a hospital, so I don't know. This is another discussion I had with a neurologist. Like, it's great to tell people that they should lower their stress, but like, what are your tools? How do we do this? And I think that really looks differently depending on who the person we're talking to is, and it's a very individual thing. So I can give you some tips on that as well. But I think, the medication compliance is something that we in the hospital see a lot as leading to strokes. So as we age a little bit, it's starting to happen with me. We become slightly more stubborn in general. I don't want to blanket statement that, but I do think it's something that does occur. And, sometimes we have doctors, I mean, even me, I'm in my 40s, we have doctors and they look like they're 20. And you're like, this guy looks like I could have birthed him. And now he's giving me advice on what to do. And I'm supposed to listen to him. So we go home and we say, well, I know he said to take this medication, but it gives me heartburn, or I don't like the way it makes me feel. So we just ignore it and we don't take the medication. This is a really poor decision. These medications, cholesterol medications, high cholesterol is 100% something we have to worry about. We need to get, that's why I say go to the PCP. We need to get cholesterol checks, monitor our cholesterol, and we need to stay on that medication. That is one of the medications I see people stop taking. And then I see them and they're having a stroke.
When you say regular PCP visits, once a year, 6 months, or is that depending on risk factors?
Depending on risk factors, it's something definitely individual that you should discuss with your doctor. I would definitely not go less than a year. But, you know, I think it's important to follow up with your doctor and say, you know, do you think I should be monitored more closely? There are people who have atrial fibrillation that will need to be seen more often and might need to see a specialist. Maybe they need a cardiologist. Maybe they need to see a neurologist for some reason, you know? So it's really dependent on you and your specific risk factors.
Is there a family history component?
Yeah, I mean, there's genetic components. So, you know, with cholesterol, it's unfortunate. You know, I've seen in my career, I did work in the cath lab for a while where we did cardiac, you know, stents and stuff. And I've seen people come in who are marathon runners, who are thin and exercise, and they just have that genetic component and their cholesterol's, you know, off the charts. And they really, the medication is the only thing that they can rely on despite being healthy. And it's because of that genetic component. And, you know, people that I have seen have had heart attacks because they weren't following up properly, despite, you know, doing all intensive purposes, doing what we're supposed to do and what we're told to do. So there is a genetic component, but again, we consider that a modifiable risk factor because if you go to your doctor and you get tested and you find out, you know, cholesterol, hypertension, those things that can be genetic, we can do something about them.
Right, right. Is there you mentioned stress, is that correlate to mental health?
Yes. So, I mean, if you're talking about a patient that has not had a stroke, right? There's a correlation, and correlation in medicine does not equal causation, right? So we don't say that it directly causes it. There's nothing that can necessarily like 100% without a doubt say that it's caused by that. But when we say correlation, it means that something happens and we know that eventually you're at a higher risk because of that something, right? That there's this kind of association that might not be causing it. So that is stress, mental health for sure. But, you know, what's interesting about science and medicine is that it's kind of a chicken and an egg situation. So if you have somebody that has high stress, you know, bipolar, you know, in certain regions, especially up here, I'm in Olympia, we have, you know, homeless population. So you have, you know, all these access to healthcare. You know, we may or may not have drug use in that situation. So you have all these things. Stress is in the bundle, but can we say that stress is what did it? Or is it there's not access to healthcare? They're not taking their meds. They're using, you know, so that's why we have what we say a correlation. There are always factors that kind of add on the building blocks that lead to stroke. It's never in isolation usually.
Okay. I appreciate that one because I've always thought it was one thing or the other. It piles up and causes the stroke.
Yeah, and depending on the stroke, right? I mean, so we can say blood pressure in isolation, high blood pressure, not taking care of that blood pressure can definitely lead to a stroke. That's a very strong statement that we can make. But with stress, we can't say that. We can say that there's a correlation.
Okay. And let's get in a little bit into how to achieve some of the blocking the risk factors. In other words, like nutrition. Are there any foods to avoid? Is there special diets you should be if you have those risk factors?
Yes. So we can Google the Mediterranean diet and we want to do low sodium. Now I've lost half your audience because low sodium tastes like we all know. We're lucky in this day and age in that there are a lot of inventive flavors that we might not have had access to previously. So it's not going to have to be boiled chicken and rice every day, which I love to cook. So that's not something I would be able to do. But you really want that low sodium. And the suggestion is there are so many amazing herbs that you can cook with that will add flavor, that will not add to your blood pressure issue. I cannot tell you how many times I've worked in the hospital and everybody goes out for Thanksgiving dinner and has all these high sodium foods, and then the hospital is flooded with patients because we have all these different issues associated with that. So we really want to look at, again, low sodium, Mediterranean diet. So we want to avoid saturated fats. I am the type of person where if you tell me I can never have something again, I will have it every day. So I'm not going to tell your audience that they cannot have a piece of bacon ever again in their life, because that would be not fair.
Yeah.
But you have to really look at scheduling these kind of cheat foods rarely so that you are fulfilling your need. You can't cut something off completely, but really focusing on having what you should have on a day-to-day basis and then allowing yourself something good when you follow that diet. So there are a ton of recipes. The American Heart Association has recipes on their page, and you can go download them for free for Mediterranean diet.
Okay.
Fish, chicken, I hate to say it, but we really should be avoiding red meats. But does that mean you can never have red meat? No, I will never say you can never have something, because that's, again, not sustainable for people. But we try to adhere to the kind of more lean meats because we don't want those saturated fats.
Okay. Is there, well, yeah, is there I hate to put it this way, but the scare factor of paying attention to the prevention part is what can stroke cause as far as long term?
Yeah, I mean, we talk about, I believe in scaring people, by the way. It's not the nicest thing, but I tell my nurses, you scare your patients when they're here, because when they leave, you want them to follow what we're telling them to do, because you want them to not revisit us. I always tell people, I love seeing you, but I never want to see you again. And I think that's where we have to think about it. You have a small stroke. People who are listening that have had strokes, you are at a higher risk for a second stroke. Higher than, even if you had all the risk factors, having that stroke elevates you even more if you do not take care of what you are going home, taking your medications that you were put on. It is so important. There are different types of strokes. We look at the cause of those strokes and we treat it appropriately. And it's really important that you take those medications. So what are the long-term effects of stroke? We already talked about difficulty swallowing, right? We can have strokes as small as numbness in a hand, you know what I mean? All the way up to something called locked-in syndrome. Which, if I'm going to be honest, is one of the more terrifying effects to stroke. This is something that occurs in the pontine or the back region of the brain. And when you have large strokes in that region of the brain, they can be incredibly debilitating and life-changing, leading to leading to death. So what happens is locked-in syndrome is where the person who has the stroke understands. So everything you're saying, they understand, but they can no longer move anything, breathe, talk. So they are basically, it's called locked in because they are basically locked in their body. And the only thing that they can do is understand and communicate, sometimes with blinks if they're able to. And that is the most extreme form I can kind of think of. But as I was saying, these are very scary things to have happen, and we have easy ways to prevent them. And the number one thing that makes me probably the most upset about this is that I go through hundreds of stroke patient charts. I've been doing this for years and years. I've probably seen thousands and thousands of stroke patients, and they don't come get help in time. That is the best. We want to do prevention, but if there are risk factors, if something happens, you don't hesitate to come to the hospital. We are here for a reason. So I think pretty much, I hope that was kind of, where we were going with the scaring thing, but there are so many aspects of strokes that can affect you and can lead to so many different disabilities. We tend to think of the like unilateral movement and that kind of stuff where you can't move your arm or your leg. But there are many other things that can happen, such as locked-in syndrome, which I think is one of the worst.
And I mean, there's issues with memory, there's issues with trouble thinking and speaking. I mean, those can be long lasting, but they also can improve, correct?
Yes. So it is true that we do have the ability, as we work with our physical therapists, who I just want to give a shout out to how amazing our therapists, our occupational physical speech therapists are at every organization I've worked with. They change, and I'm sure you can agree, they are life-changing individuals and really inspirational to our patients. But when you work with your therapists, and it's ideal kind of to start sooner rather than later. There's kind of a debate as to whether or not the first 24 hours, blah blah blah, but we'll ignore that, and we'll say, like, after 24 hours we really want to start moving and working and trying to regain what we can. There is this neuroplasticity aspect to it, where we can start to develop things, pathways, and really kind of improve. Some people will see a significant amount of improvement. The brain is the most complex organ. I don't care what anybody else says. So everybody's different. And that's why it's so important, rather than, even though there is a chance that you'll have improvement, it's a better chance if you don't have the stroke and we can prevent it, even if it's your second one. Because I know a lot of your audience. Just because you had one doesn't mean that we don't have to worry about not having another. It's the opposite.
Right. I appreciate all you've said. I mean, my recovery became remarkable after 6.5 years. I mean, I'm off of cane and those kind of things, but I wish I would have known a little better about prevention. I was concentrating on my heart, with diet and exercise and those kind of things, but I never thought a stroke would happen to me. I mean, it's crazy that it did, but is there anywhere else that we can, I mean, everybody talks about prevention for all kinds of medical problems, but stroke is probably one of the highest incidents, or the highest incident of disability in the United States, correct?
It sure is.
Wow.
It is the number one cause of long-term disability in the US.
Okay.
And you know what the sad part is that it's not the number one cause of death, so we don't get as much focus.
There you go.
And that's really the issue.
That's the point I was hoping to get to. Good. Thank you. Any other suggestions for getting more information regarding stroke prevention?
I mean, I think that again, I don't know I feel like I'm being repetitive, but I don't mind being repetitive when I say this, that following up with your primary care physician and discussing things with them and finding out what your risk factors are is the first step. I think that, again, for our younger audience members that are hearing this, stroke is not an old person disease. That's what I've heard before. Stroke is that's what people have said, which is A, insulting, and B, untrue. So, everybody can have one. There's a correlation. This is one that this is a big one. And I know we know people that this has occurred with. Complex migraines in females. I'm going to go on my soapbox here, because sometimes cardiology gets a little bit more exposure. So we have this whole big go red day for women. Don't ignore the symptoms for women for heart disease. And it's a big movement across the country. Well, women have a higher incidence of complex migraines. Complex migraines have a high correlation with stroke. They do. And and they can even mimic stroke. So we have people come in, they have very similar symptoms to strokes, and then it turns out it's just a migraine. Just a migraine is not meaning that next time it will be just a migraine. So we label people unfairly with this kind of, oh, they have a complex migraine, it's just another one of those. And then people take that and they ingrain it in their head and they say, oh, it's just my headache. And that time it's not.
Okay.
So listen to yourself. Listen to your doctor's advice for treatment. Listen to yourself about your own body. If something feels off, do not assume that it's going to get better. Another thing I wanted to mention while we were on is that women who are younger on birth control are also at higher risk for stroke. So we do see females, especially if they're smokers, right? Younger smokers that are on birth control. We do see females that are younger that have strokes because they're on birth control. It does predispose them to this clotting issue.
I had no idea.
Yeah. So does that mean I'm trying to scare everybody off birth control? No, because we don't know that that's, but it is something that occurs. And so again, these are the people that ignore it because it's just we think of it as something that occurs only after a certain age. And I hope these numbers I'm quoting really help people understand that that's not the case.
Right. Well, Laura, I think we've covered a lot. I hope we can cover more in future talks, but anything else you want to add, or you think we've got it for today?
No, I mean, I think, this is a great audience. I hope they, they get something out of this. And I would love to, be able to come back and kind of elaborate more on kind of some positive notes, because sometimes everything I say is a little bit shocking, but there's positive sides and fun ways to kind of adhere to these prevention strategies.
Well, I wish I would have been shocked before mine, so I appreciate what you're doing. Thank you, Laura. I appreciate it. You have a great day.
Thank you. You too.
All right. Talk to you soon.
Okay.